this case presentation will just be an extension of the learning that we had through the drawings that he has made. And we just want to see how we can make these embolizations safer for the patient. And being safe is always learning our anatomy and knowing the points which are presumably dangerous and should be kept below our point of embolizations. So the cases are chosen in such a way that this highlights the entire teaching that we had. And I will just ask the audience to be with me. This is a very simple case, not a very significantly elaborate one or a demanding one. But yes, we have to apply our anatomical knowledge to the present scenario. So this was a presentation of a 62-year-old hypertensive male who complained of a thunderclap headache and vomiting without any neurodeficit. And he had a neck rigidity as well. This was the CT scan, which showed some amount of blood there. And we were not expecting the pathology that we ultimately arrived at. Coming to the CT angio of this patient, this was his CT angio. So we had that globular structure which was been marked out, and this is ahead of anything near the circle of Willis. So this is ahead of the circle of Willis, not in the ACL territory as well. So something which is much ahead in the projection. So we went for a DSA. Now, as we have seen in the drawings, this is the ophthalmic artery, and it ultimately forms this dural fistula, and this is the venous part, and this is the anterior-most part of the superior sagittal sinus. So it has obviously got bilateral connections because this is a midline thing, midline malformation. So we have a supply from the left ICA and also a supply from the right ICA. So both the ophthalmics going forward, meeting in the midline and forming this malformation and ultimately the venous part of it. So let's have a real-time look into this, how this looked. So this is the point where it makes the fistula, the distalmost part of the ophthalmic going here. So this is the entire journey of the artery, and finally it makes it anatomical connection over here with the, let's look at it again. This is the venous part. So this is the right side. So this again is the left-sided injection. So this has got its supply from both the ICAs. This is the terminal most part of convergence where both the systems converge. So obviously, as we read the literature, there are two very eminent ways of dealing with such kind of malformations. You can do it through the arterial side, you can come through the venous side, and as well you can have a surgical approach. So after going through the various options, we chose the arterial way of taking out this connection. So while we were into the case, we made 2 groin accesses. We had 2 envoys placed in both the carotids, and we did a simultaneous injection from both the carotids. So we can get a better understanding of how the 2 systems actually converge, because the other 2 pictures were 1 injection at a time, the right side and the left side. So here when we inject both the sides together, this is how it looks. This is one ophthalmic, this is the other ophthalmic, and this is the final common drainage point. So it doesn't like you need not debate on which side to take. The final common point has to be taken coming from either side. Whichever you are comfortable, you can go through that. So you need to have some catheter at this point and inject whatever you feel will do. It can be glue, it can be onyx, whatever, and just to take care of this segment. So if you are good at it, then you have successfully taken out your problem. So now what has already been evaluated and told in great details, the twists, stance, segments, and safety, because we are concerned about the vision. So coming back again to the same drawing, the same thing in a diagram. So the first part, the angle which has already been elaborated, it sometimes goes below, sometimes takes the turn from medial to lateral, most of the times. This is the bend and the third part of the artery. So once you are beyond this anatomical ring and the origin of the central retinal artery and the long ciliaries, you are safe. So you have to navigate beyond this, and anything beyond this, the more distal, the better. So for this transarterial route, this presentation is of paramount importance. Actually, if somebody knows the anatomical disposition, I think these lesions are very safe to deal, and this is a mundane case. This is nothing very significant, but knowing the anatomy is the key. Okay? So that is why he has taken that extensive amount of research and pain that he has gone through in putting such beautiful pictures. So this again is another case where this has been taken from the angio.org. So this again represents the different bends of the arteries and the different things which has already been shown. So I will not go into this. This is again a cartoon demonstration of the same thing. So we can call it an ethmoidal dural AV fistula. In our case, usually supplied by the anterior ethmoidal arteries or falcine branches of the ophthalmic artery. As there is no dural sinus around the anterior cranial fossa, the venous drainage generally flows directly through the intracranial cortical veins, chances of bleeding, which ultimately drains into the superior septal sinus, inferior septal sinus, or the cavernous sinus. Now in our case, bilateral ophthalmic artery supply, entry point of the fistula is distal to the central retinal artery and the frontal cortical vein, which ultimately connects, as we have shown you. So cause of bleed, no dural sinus nearby, cortical veins are recruited and venous ectasia, and the lesion bleeds. Location of the bleed is usually frontal lobar, but it was not the case. It was not the situation in our case. So again, the treatment is endovascular, either transarterial, transvenous, or you can do a surgical resection as well. Transarterial route is challenging if you don't know the anatomy, otherwise it's very safe. First and most importantly, several authors have warned of the risk of embolization of the CRA. So this is if you stay proximal and inject. So Anybody into this practice will know that the more distal you are, the more safe you are, the closer to the lesion you are, the more safe you are. So a proximal injection, as he has shown somewhere from here, is absolutely not done. So you have to cross the origin of the CRA and the ethmoidals of the ciliaries to be safe. Second, the small caliber and tortuous course of the ophthalmic artery, ethmoidal artery, and various venous drainage routes can make selective catheterization very difficult. Third, unlike embolization of other dural AVFs in which the blood supply originates from the ECA, embolization of ethmoidal dural AVFs through an ICA branch carries the risk of embolic agents refluxing into the central circulation. However, this is an extremely unlikely scenario and should not happen. Now, regarding choice of the embolization materials, these are of course theoretical lectures, so you need not bother about what you are using. If you are at the right place, anything will do. 0.1 ml of glue will do, a little of amount of onyx will do, just we'll have to be sure that we are into the venous pouch. Now, unilateral versus bilateral cannulation, since this has got both the sides recruited, simultaneous check is required to identify true obliteration. So once you are obliterating from one side, you can always check through the other side whether you are leaving something behind. So having bilateral cannulation is always helpful. If drainage route is single, aim is to reach foot of the vein and disconnect the route from both arteries, which can be achieved by putting microcatheter through one artery and embolizing the common channel. So that is the ultimate goal. Now this was what we used for this case. And here is this is the final point where we had our catheter tip, and after that everything was very easy. So this is the movement of the embolic materials to the foot of the vein. So once that is done, we again take a simultaneous check shot from both the carotids. So this is the left ophthalmic, that is the right ophthalmic, and that point where it made a connection with the venous system is gone. So this is the lateral view, this is the epi view. So you know that the lesion is cured now. And obviously the eyes were preserved because we were working far ahead of the origin of the neural branches of the ophthalmic. And this is the choroidal blush, as Rahul said, not from the CRA but from the long ciliaries. And this is the cast of the material that we have put here. So this again is a literature search we did after, and this shows that both the more than 50% chances of success by EVT transarterial, so worth giving a try. And to announce the last that we are going to organize the INSC 2024 in Kolkata next year. So please be with us. We will have many people from this forum actively participating in that. We will have Rahul, we will have Kaushik and many others, Professor Alurkar. So these are the international faculties that we are going to invite. They have actually agreed to coming and being with us for those 2-3 days. So thank you again. Thank you, Rahul, for giving me this opportunity.
Excellent case, Dr. Deep. So now we can have some comments and discussion. Anand sir.
Both the talks were excellent. Rahul, you have done a great job as usual. You are a master of anatomy. and I'm sure all of us have learned a lot of things. Deep, that was an excellent demonstration of safe embolization.
Thank you, sir.
Great.
Any more questions? If you want to discuss about the technique, he has used onyx. The subsequent cases that I will show, I have used glue. So if you have any questions about onyx, I think this is the time to discuss with him, because I will not be able to answer those questions. So Deep will answer those questions.
Sir, microcatheter which was used was Apollo detachable tip, sir.
Yeah.
Okay, we can use it.
See, it was a time when I was not very confident with glue. Still I am not, but that was my learning curve. So I chose something which was safe for my scenario. But again, any catheter, 40%, 30% glue will just work fine. You don't have any chance of a stuck catheter at that point, at that place, so you can take it out. So a glue will work as well as any agent. So the question is not about the agent that you are choosing. Okay? The question is about being how distal you can be and to the lesion itself. So that makes it a safe procedure. And if you are at that position, you can inject anything. It doesn't matter.
Any more questions? Onyx guys, any more questions? Would coils have worked for this?
I think no, because you have a contralateral supply from the other side, and unless you are into the foot of the vein, it's not done. So you have to penetrate into the venous part.
Sir, did you take the ECA run at the end, sir?
ECA, the ECA run at the very fast stage showed that there was no supply. So no.
Any more questions? Philosopher, sir?
Venous route, I have not done any such lesion through the venous route, so I can't say. Possibly Rahul will say.
Yeah, I will show that. Venous, I'll show. First of all, we'll see the case that I had promised in the previous lecture. We will see that case first. Ethmoidal dural AVF. Yeah. Kaushik, what do you feel? See this, I'll run it once and then I'll stop it at the relevant place. So this was the case that we had. So what do you feel? What is it? I mean, just collect your thoughts and just tell me what do you think this is. Yeah, this was a patient. He was found unconscious at home, and this is what he came to us with. What was, in fact, there was a history of maybe a fall. He was found on the ground. He was sitting apparently soaking up the sun in the Patna winter. And then after some half an hour, someone came and he was down on the floor. So my emergency guys, they saw this. The first thought that they had is it's an extensive subarachnoid hemorrhage. Patient was absolutely well till around half an hour back before this. So the history is only half an hour. So extensive subarachnoid hemorrhage. But what is more, exactly. So you have a load of hypodensities typical in the MCA territory.
The distribution of the hypodensity is more arterial rather than something like a confusion.
Exactly. So it is not just peri-hemorrhagic. It is in the MCA territory. So what we saw is, then how do you come to a unifying diagnosis? You have a patient who has come to you around 4 hours or 6 hours after the onset. I mean, this was a scan. By the time he reached us, it was that much time. But you have a well-formed infarct in the MCA territory, and you have sulcal subarachnoid hemorrhage. Extensive, thick SAH. So how do you unify this now? I mean, I couldn't in the beginning. So we could not unify this, and obviously we stabilized the patient, and since the hypodensity was already well formed, we knew that opening the vessel, if it is a MCA occlusion, is of no use because it's already infarcted. A lot of possibilities were going on in the mind. So one unifying diagnosis in which you can have hemorrhage and ischemia is a dissection, yes. The second is he had an MCA infarct, fell down, hit his head, and then some artery bled. So all these were the possibilities that we were thinking of. Took this patient up for an angiogram, and this is what we saw. So very fast, but okay, fine. Lateral we can see at least. So now, what do you feel? This is a CCA injection. This is a common carotid injection. 3D, I mean common carotid 3D. So what do you see? Obviously, the ICA is completely missing from the picture. What you are basically seeing is just the ECA. And you are seeing a good amount of collaterals. And in fact, in the DSA, in the cine run, in the later phases, we were seeing that the ophthalmic artery collaterals are quite robust, and they were supplying a significant part of the supratentorial region. The MCA, in the very late phases, was filling up from the ophthalmic collaterals. So still, we are not able to explain the hemorrhage as of now. This is not even a hemorrhagic transformation of an infarct, because this is in the sulcuses. This is subarachnoid. So then we started looking at this image very carefully, and what we did is we took the CT, we took the epicenter of the bleed, and we superimposed our 3D on top of that CT, exactly cut by cut. So what we found is, at the epicenter of the bleed, this is the ophthalmic artery. You can see there's a huge ophthalmic artery. It's quite thick. This ophthalmic artery has been reformed from the injection into the ECA, because basically there's no antegrade flow in the ICA. You can see all these are the osseous branches that are trying to make communication through the bone, through the internal carotid artery territory. But what we saw is, we saw a very suspicious thing over somewhere here. We saw that this is the junction where the ophthalmic artery is going to meet the supraclinoid ICA. The supraclinoid ICA is on the medial side. It is somewhere here. But what we saw is, we saw this structure which was pointing laterally. We'll show you many more images. Epicenter of the bleed, that structure right in the epicenter. Epicenter of the bleed, that structure right in the epicenter. And this is what we saw when we did the subtractions and when we removed all the bone. We saw that this is the ECA branch which is coming and reforming the ophthalmic artery. And just when this is going into the MCA territory, at that point, you have an aneurysm. And this aneurysm or dilated structure or bleb or bulb or stump, whatever you want to call it, was the one which was corresponding with the epicenter of the bleed. The thickest subarachnoid blood was in this area. So, I mean, we could not find any other explanation for the blood. So this is what we found, and this is known. This has been described in a few cases in which you have a chronic occlusion of the ICA, a subtotal occlusion, which gives you time for the collaterals to develop, and then one fine day that goes from subtotal to total. That is the day you have probably the ischemia. Because of the ischemia, you have hypertension as a protective response. Hypertension causes this aneurysm to bleed. This is what has been published. We have also sent this. Let's see what happens. So this was the entire ECA. You can see that the ECA is very, very robust. And this is, I think I should be having one lesion in which this is a translucent skull superimposed. So these arteries which are very, very prominent are extracranial, and these arteries which are not as prominent are basically intracranial. For example, this middle meningeal artery, this is intracranial. This is the communication of the ophthalmic artery through the nasal branch of the facial artery. The nasal branch of the facial artery is ultimately anastomosing with the branch that is coming from the ophthalmic artery. This is reforming the entire ophthalmic system. This ophthalmic system is leaving. In fact, the flow now is reversed in the ophthalmic system. The ophthalmic artery is leaving via the orbital canal, and then ultimately it is reforming the MCA distally. And where it joins with the ICA stump, that is where we had the bleeding point. So this was a case. This is
Occlusion was chronic. Why did he develop the infarct?
acute and chronic. I mean, it must have been subtotal. And then that fine day, he must have completely occluded it. I mean, can't see anything. So, I mean, you're thinking that the SAH was primary. We don't know. We don't know. No, from below upwards. I mean, from the bulb onwards. So I mean, see, these will just be hypothetical. But the important point to see here is that there is a collateral which we have discussed in the anatomy, and this collateral was trying to fill the brain. And obviously, if it's an aneurysm, it has taken quite some time to develop. It will not happen immediately. So because of high flow, a flow-related aneurysm was developing, maybe. Maybe he had the SAH, because of which he went into vasospasm and he developed the infarct. We don't know. We don't know which came first, but at the end of it, this is what happened. Within 6 hours. So it is very robust. So that means ischemia probably was the primary event.